Okay, let's start. Good morning, the people in Minnesota. I always butcher it, and good evening, the people in East Africa, mostly Kenya. Welcome to this session. We're going to talk about dementia, and as the flyer you saw said, we are trying to demystify it. And so we'll start with definition. So of course that honors will fall on the medics, and I'll go with you, Katie. Can you define what dementia is? And if you need a brain, I can pull up a brain.
So basically, dementia is a decline in cognition. So basically, a decline in cognitive function. It can be in a multitude of different places, including learning or memory or language, or your ability to attend to things, your motor abilities, your social abilities, but basically a decline in those that is progressive over time.
Okay. And Judy, do you, if you want to catch me if you can, do you concur? Do you concur with Katie? And if you want to sprinkle anything else, you can sprinkle in some Kenyanese and just tell us why and help us stop calling all dementias Alzheimer's. Like, give us a broad category of conditions that are considered dementia. I don't know, English, yeah. Does that make sense?
Yes, it does. Thank you, Kosa. I fully agree with what Katie said. I would probably not have much to add. A lot of times people think that dementia is simple forgetfulness, and so that seems to be what everyone seems to be looking for. But just as Katie said, there's a lot more that goes in, and it's not just forgetfulness, it's your inability or your declining ability to, just perform your tasks or plan your day and execute those tasks in a logical way, and it declines over time. So probably the other thing I might add is that dementia is more of a broad term. So if we think of it as an umbrella, dementia is the big umbrella, whereas there are little different types of dementia. And even though a lot of times we seem to use the word Alzheimer's and dementia in the same way, Alzheimer's is one type of dementia. Granted, it is probably the most common type of dementia, but there are other types of dementia and things that might have a lot to do with your blood supply to the brain, what's called vascular dementia, the dementia that comes up when you have Parkinson's disease in the later stages. You get a Parkinson's disease dementia. And just like you've put up now, there's also, the Lewy body dementia. So there's slight differences, but Alzheimer's is the biggest part of dementia. So maybe that's why people use the terms interchangeably.
Okay, and in terms of what you see in the population, Katie, what do you see mostly here in Minnesota and in the States in terms of the percentages that I've put up on the screen? Are they, is it what you're seeing, and is there a difference with the BIPOC population?
Yes, so it is pretty similar to what you see on the screen. In Minnesota, I would say vascular and Lewy body are more equally represented in the population. However, in the BIPOC community, vascular dementia probably outstrips the Lewy body dementia in terms of numbers. The reasons for that are varied. Vascular dementia has to do with, it tends to be related to chronic diseases such as high blood pressure, high cholesterol, diabetes, and those diseases are overrepresented in our BIPOC community here in Minnesota.
Okay. And Judy, is it the same thing you're seeing back home? Like, what's if we have numbers? I know we have to start with the disclaimer. If we have numbers, what kind of numbers are we seeing?
Okay, actually, thank you for that. I was going to put in my first sentence. So we don't have a formal registry for dementia patients within the country. So what that means is that with numbers, I will be really taking a guess, but remember, I see a skewed population of dementia patients. So just judging from the sort of patients we see with dementia, I would say it does look quite similar. We do have the largest body, which would be Alzheimer's. We would have second, vascular dementia, just because, as Katie said, it follows chronic disease, diabetes, hypertension, high blood pressure, problems with your cholesterol, vasculitis or inflammatory diseases. And so we, a lot of times, are not able to accurately identify Lewy body dementia. So it's a diagnosis that we might not make very commonly in country. It might need to be aided by the diagnostics that would be outside the country, or we might need to be making clinical judgment. And by that, I mean little investigation, but clinical judgment based on how the patient presented, like if they had some Parkinson's and they had this very early onset dementia, which we don't typically expect in Parkinson's patients, then we'd be thinking about something like a Lewy body dementia. So yes, I would say it is quite similar.
Okay, and let's go to Bugo and then Manka. Bugo, do you, first of all, happy birthday to Jerioth. Bugo's mother is turning 84, and the birthday is today, and she's honoring us by joining this meeting as she monitors who's not burning onions on the side. So happy birthday, Jerioth, and Bugo, thank you for doing this for us. And so, Bugo, does Jerioth have a diagnosis as yet?
Yes, Jerioth was diagnosed in 2015. So she did see a neurologist and she saw a psychologist, a psychiatrist as well, not psychologist, psychiatrist. So she got a double diagnosis, yes.
Okay, and Manka, you can tell us a bit about the memory, the Minnesota Memory Project. What informed this project, and what so far does the population you're dealing with? I know we've collected a bit of data. Does the population we're dealing with actually understand what dementia is?
Thank you so much, Kosa, for having me on the panel. And yeah, the Memory Loss Project, basically, it's a project that came from the community. So what happened was the community partner was witnessing that there was a lot of dementia happening in the community. Let me call it the official title. But what was happening was that it was going unnoticed. The caregivers were struggling with how to care for them, and the general community had no understanding. But basically, our community partner thought, is this something that is just happening with what we are seeing, or what is happening in the greater African immigrant community? And so they approached us at the University of Minnesota saying, this is something that we're witnessing, but we want to really understand a little bit more and know if it's just something that we're witnessing within the communities that we're exposed to, or this is something that is happening generally within the African immigrant community. And we know that dementia, the prevalence is high in racial and ethnic minorities, and African immigrants are racial and ethnic minorities. So the other question was, if Black people who have twice the risk of having dementia and African immigrants are Black, are we having that? Is dementia as prevalent in our own community as it is in the regular African American community? And so that was some of the things that the community partner was thinking about and the research team was thinking about. And so we decided to now work together, the community partner and the University of Minnesota team, to get some funding, because as you know, unfortunately, research is often difficult if there's no funding to help support the people that are doing the work. So we got a grant to go do this project. And we thought about the name of the project a lot. As the medical experts on the panel have said, they've called it dementia, but unfortunately, the community does not recognize it as dementia. The community also stigmatizes dementia. We can talk about the stigma attached to it a little bit later. And so what happened is we called it the Memory Loss Project, because that was the name that we felt was a little bit palatable to the community. And so basically that project was now us, the university and the community partner going into the community to really understand the needs of the community related to memory loss and dementia. And then in addition to that, we did not only think that the community had needs, we think that communities often have assets. There are strategies that people have been using. So we wanted to understand what are the assets, what are the things that people were already doing that were working. And so we started this project by having some community conversations with community members. And as we began having the community conversations, I think the first one was held in the Brooklyn Park City Hall. Everybody there said there is a need for education in the community. The second one was held at the Organizations of Librarians in Minnesota. Everyone there said there's a need for dementia education in the community. So what we're finding so far is that there's a huge need for dementia education in the community. And there's quite a few people who are actually caring for relatives with dementia in the United States. And also interesting is that there's a lot of people who are living in the US right now and they're caring for family members back home in their country of origin in Africa. There are people who are caring for people in Kenya, Nigeria, Cameroon, Liberia, different African countries with dementia, but they're living in the US and they're providing education to family, they're providing resources and finances. And so there's a lot of, those are some of the things that we're finding, but I can stop there and let you ask me any more specific questions and I can answer.
Okay. Unless does Katie, do you want to ask Manka anything, because you see she's seeing some of the patients you're seeing, and is there any question you have for her at the moment before we move on to something else?
I don't really have any questions. I would say I appreciate all the work that we do. I have had a lot of patients over the years. Actually, I've had some of my family members of patients bringing family members urgently to the United States because of a sudden decline or a difficulty getting a diagnosis in their country of origin. And occasionally when, they'll bring them to the United States, sometimes in kind of extreme circumstances when things have reached a point of not being, very manageable. And then it's always a tough situation for my families here, trying to figure out how to get that person the care that they need. And so I really appreciate all the work that you do, because I feel like there's a need across the whole country, but also, between countries, and trying to help get people the care that they need, and also to recognize all the good work that families do to help keep people healthy and strong and working well in families. So thank you for that.
And that's one of the reasons that I do this kind of talks, just to, because I straddle both worlds, and the knowledge sharing from two continents at the moment is important, because you see we are caring for relatives who are not here and sharing information back and forth, and it's very good for the world. Maybe we might achieve world peace that way. Okay, so I just want us to go back to understand. We've defined the abnormal, but I want us to look at what's normal. And Katie, Katie, I don't know how good your step one is, Judy, I don't know how good your anatomy demonstration days are, but let's let me see. Are you able to see that?
Yep.
Okay, who do you want to take a stab at what normal brain anatomy and its functions are? Because this way we'll understand dementia is more than just a memory problem. And even though the African community prefers to call it a memory care issue, it's just more than the memory. So I just want us to go through the anatomy and, if possible, the physiology, as in how the brain functions, so that we know when it doesn't function, what's happening. Katie, is your step one that good?
I'm laughing because that's an enormous question, a big ask. So the brain, I would say, just to put things in perspective, as a neurologist, I would say that we know probably less than 1% about the brain at this point. I think what people don't realize is that the brain is probably the most complex organ ever made in the history of everything. And we are just at the very cusp of trying to understand its mysteries, right? And so the normal brain and its functions, this is a beautiful display. I just want to give an idea. So the most important part as a neurologist, when I'm talking about to people who are in my patients, for example, the most important part of trying to understand the brain is that the outside of the brain is called the gray matter. It's the cortex, right? It is full of neurons that basically transmit electricity. That electricity then gets transmitted to other neurons that then releases chemicals and causes things to happen. And it's a cascade that happens within, we're talking split seconds. So you are unbelievably doing millions upon millions of different things at once inside of your brain to cause you to be able to walk, for example, or talk, for example. If you think about everything that has to combine in order to allow you to process information that you're seeing, information that you're hearing, sieve out or take out from that what's important, and then assimilate something, and then come up with something that comes out of your mouth. That takes an enormous amount of processing energy that, even computers that we have now don't really actually meet. So it's an amazing thing. In terms of normal brain function, if you're looking at the anatomy itself, so the outside part of the brain is called the cortex. The inside part of the brain is the white matter. The cortex is filled with neurons that are processing information. The white matter is like the cables that connect things to each other. And what you're seeing on your diagram right there is basically the cortex and what we commonly see the cortex doing. And when we're talking about dementia and memory, we're different parts of the brain and the brain's cortex are responsible, we think, for certain processes. I'm going to move my thing closer here. So when you're looking at like the temporal lobe, for example, we traditionally consider the temporal lobe a part of memory, and the frontal lobe we consider to be part of higher executive functions like your ability to have good judgment, your ability
and Katie, you can just
impulses.
mention the color.
Oh, I'm sorry. Yeah. So
you can say red on this.
Yeah. Okay. So the red part there is the frontal lobe. That's what I'm talking about now. That's involved with things like your ability to have good judgment, your ability to inhibit impulses, your ability to complex process certain commands. When you're looking at the green part there, that green part, that's like side part, that's called the temporal lobe. That's what we traditionally associate with memory. Both the front, that red area, and the green area, those are very important in dementia. Oftentimes when we're looking at a person with advanced dementia, and you are to take a picture like an MRI or a CT scan, you often see a reduction in size of the cortex of those areas because there is attrition or loss. There's a loss of cells in those areas. However, it's not just limited to those areas. It's all over the brain, but that's traditionally what we see. I think importantly, what you see with dementia is truly a loss in all areas. It's just that those ones are overrepresented in certain types of dementia. Does anybody want to add more?
Judy, are you still on the, because of sharing the screen, I can't see people very well. Judy, are you on the call? Are you still there?
Yes, I am.
Okay.
So Katie, that was an amazing brief on a picture sprung up on us. I was starting to panic. I was in a cold sweat. I was thinking, where are the pictures? Where do I put my phone? Anyway, but that was amazing. And that's absolutely right. So I think the picture you're sharing now on the left of our screen shows a normal brain, and you can see like all those, so the brain is a really, really huge surface area, but because it has to be contained within a relatively inelastic, or, you know, a relatively stiff bone called the skull, the only way to do that is to fold it up, you know, like in a Marie Kondo sort of way. So the brain has all these folds and gyri, and that's what they're called. And on the right, well, on the extreme left of your screen, you're seeing a normal brain, I'm assuming postmortem, and you can see the beautiful folds of the gyri, which are the folds, and then the holes in between those, the sulci. But when, as Katie said, you go through the process of dementia, which is over several years, this is not something that will happen in days or weeks, and unless in very rare circumstances, you see a shrinkage, which is really quite evident on the next picture. So that's a picture, I think, depicting a patient with Alzheimer's disease, and you can see quite a lot of shrinkage. So because of that, the spaces between the gyri seem quite exaggerated. And that's typically what we'd see in patients with Alzheimer's. I will mention now that sometimes, and in fact, a lot of times, we are not able to see these differences so well depicted. And so it's quite often, and I think this can be frustrating for the patient to hear, that you will go in for a brain scan, an MRI scan, and it comes out looking relatively normal or with just a little bit of shrinkage. And for the patient, that can be confusing, because you're thinking, well, here I am having trouble, you know, just planning my day and with my memory, and my family's telling me all this, and then you tell me that my MRI is normal. So these are really tests that we do to enhance our suspicion of the diagnosis, and not necessarily to come up with an, you know, 100% surety that this is it. So we use it, and it's really a game of possibilities and probabilities. So we use this, and if we see the shrinkage together with other sort of behavioral changes that you're going through, then it strengthens our diagnosis. And that's why sometimes the diagnosis is not a spot thing. We might need to follow the patient over time and then gain strength in our ability to diagnose. So I think what you show on the right of the screen is looking at it from a cross section. So this side, in this picture, you can see what Katie was talking about really well, which is on the outside surface. It does look more gray than on the inside surface. So that's the gray matter, which is packed with cell bodies and the neurons. And then the white matter is, like she said, the cables, the electrical wires transmitting this all over. And on the right of that, you can see quite a bit of shrinkage of both, you know, of that particular area. So looking at this part of the brain, you can, well, you can't tell, but this is the temporal lobe, which is what we would focus on in patients who specifically have Alzheimer's dementia. So the temporal lobe is
green. Yeah.
Right. Okay. All right. Right. The temporal lobe was the green, number 2. Absolutely. So that's what we're seeing, a cross section of the temporal lobe, and that's really quite typical for Alzheimer's dementia specifically. So once we see that, it really, like I said, medicine is a game of probabilities. It really increases our confidence that this is more of an Alzheimer's type of dementia rather than the other types. But we must remember, sometimes God has a sense of humor and gives you different things. So just because you have Alzheimer's doesn't mean you won't have a little bit of a vascular component as well. So yeah, I think that's all I'd add.
Okay. Sometimes I just wish someone could make like that slide. I mean, a beautiful, you know, this is colorful, the equivalent, but the pathology one. And I hope people are understanding the connection, like all this beautiful stuff. And if you look at that hard word that the H word that shows you the part of the brain, and like, let's say, look at where the lips, the eye, it's on to the right of my screen, that part of the cortex. If that shrinkage happens to that part, you can imagine that person will have issues with their lips, their face, and all that stuff. Like, think about the visual cortex, which is at the back of your brain. If this shrinkage happens to it, it explains how people lose vision and start falling, because they were previously 20/20 vision their machicios, their glasses are not working anymore, and they keep falling. And this, with that said, we'll move to presentation. And I'd like, this is for Bugo now. How, I know you started off with a psychiatrist in Gerion's case and then landed with a neurologist, but how did you first realize that Gerioth is not your Gerioth, or when you were in Nairobi Primary School? Bugo, are you checking on onions? Okay, she's here.
No, my son is asking for ice. Well, with Gerioth, it started with her friend, her best friend, would tell me things that happened when they were hanging out. So, for example, they traveled to Israel, and my mom, and when they got to the airport, she lost her luggage. She picked someone else's luggage, and we had taken the time to mark her luggage. It was bright colored, but when she got on the other side, she picked someone's luggage, and it was a big deal because they were going in different directions. And by the time they sorted that out, so her best friend was like, that's not like her. She's usually so meticulous about things, and so she would say things to me, or they would be driving with the driver in the car, and then they had a fender bender once, and the driver stopped to address.
And is it me or Bugo is getting lost? Bugo, climb a tree. Okay, I will mute her for now until she's back. But let's just talk about the symptoms. Manka, what is the community saying? What? Bugo, I'll mute you for now. Okay, Manka, what is the community saying? How are the people presenting? How do they know that dementia is? Okay. Okay, I think she's, yeah. What are you hearing from the community side?
I think it often starts, like Bugal was saying, with the memory. And so people begin to notice that grandma, grandpa, or mom and dad is forgetting a lot of things. And then you're like, oh, mom put a pot on the fire and then completely forgot that she was cooking, and so it got burned. Or mom went to the corner store to go pick up something and forgot about it. Or mom forgot that her own mom had passed away. I think that was a story where people kept on saying, the mom kept on calling and asking, how's my mom doing, when the mom had passed away. And so it was the classic sign is that loss of memory. But what is interesting is that families always say that, oh, they noticed it very early on, but it just thought it was normal. And then it was when something catastrophic, I think the classic case of catastrophic is a pot burning on the fire, or family members getting lost. A lot of people talked about, oh, my mom normally would just walk across the street to do this, and then she went for a walk and got lost. And so those were the things that would say, oh my God, there's something going on. So I think in the community, the biggest symptom that people recognize is loss of memory. Yeah.
Okay, hence the name, it makes sense to call it the Memory Project then. I'm reintroducing the panelists for those who were on heaven-bound time. I'm just introducing them as because they are the way they line up across my screen. On my Manka, you can wave. Manka is a PI, is a principal investigator of the African Memory Project. It's a dementia project, basically, based here in Minnesota, in the United States. I'm Posa, I'm the host. Katie is a neurologist based here in Minnesota also. Judy is a neurologist based in Nairobi, Kenya. And Bugo is a pharmacist, but she's here as a caregiver to her mother, Gerioth, who's turning 84 today. And we've gone through definition. I'll send the video out later, but we've gone through definition. We've gone to, we've tried to understand what's really happening in the brain. And now we are going to how dementia presents. And basically what Manka and Buo have mentioned is the memory loss part. And now we're going to go to the doctors who will tell us what they're seeing on their end. And Katie will go, yeah, just the way you're lined up on my screen again. Katie, what are you seeing? And it's for both BIPOC and the Caucasian and the, I don't know what, yeah, the Caucasian side. What are we seeing?
So everybody presents a little bit differently, I would say. Memory loss is the most common presenting complaint. So oftentimes what we're seeing is generally speaking, it's a family member or a friend who is saying that their loved one is just not the same and is not able to do the things that they were able to do before. Perhaps they're, I often hear people say, mom or dad or grandma or grandpa, they're repeating the phrases. They are, whenever I'm telling them a story, you know, I get asked to say, they ask me the same question again in another few minutes or another day, or they don't recall things that we talked about yesterday. So commonly that's the most presenting complaint that I get from people. It's pretty rare to have the person themselves or the patient themselves present and say that they think they know. There's off kind of a blindness in a way to their own inability, which is interesting. That's not always the case, but that's often the case. Many times, and yes, I agree with this slide. That's how they present, and then we start asking further questions. Right? Are they having difficulty performing their activities of life? Are they struggling to drive? Are they having trouble getting lost? Are they having any problems with their mood, their behaviors? Are they starting to be more irritable? Are they having difficulty sleeping? Is a common thing that we see too. People who are starting to develop dementia often will struggle with unusual sleep patterns or start to have difference with maybe acting out their dreams, things like that. Are they having problems where they can't control, like I said, with their emotional state, more irritable or perhaps behaving very unlike their normal self? Like usually mom or dad is very calm, taciturn, has never been a complainer, but suddenly they're stormy emotions up and down, or perhaps they're more depressed. And that's another interesting one. Sometimes they say mom or dad is just more sad, more down, is crying, is feeling more depressed. And one of the things that is very difficult for us in the medical field is to help determine whether people's difficulty with memory or their difficulty performing their normal tasks is related to truly a mood issue, or if it's related to a medical neurologic loss of function in dementia, or if they're concurrent, because they can be concurrent. And so that's actually one of the things that we struggle with a lot. But that's kind of how most people present, is usually with a loved one mentioning that there's something different, something has not been right. And it's usually they're saying over a period of time. You know, I work both in the hospital as well as in the outpatient setting. And in the hospital, we see people say, oh, mom or dad was just fine until 2 or 3 weeks ago. But when it comes to dementia, what we're often seeing is just this very slow, progressive decline. Although with certain types of dementia, it can be very quick. So like I said, it can be different for everybody, but that's commonly what we see.
Judy, what are you seeing back home? And can you, when is it not just a senior moment? When is it the same way I'm graying my hair? When is it just not old age?
Okay. I echo a lot of what Katie has just said, especially as regards the fact that as the patient, a lot of times you will be, as she put it, blind to the situation. I mean, you will probably notice that there's a problem, but because it's such a slow progression in majority of the cases, it's something you might not take quite seriously, or it'll be so little that it doesn't really affect much of your functioning until later on. So it's usually a loved one who comes in. So in many ways, that sort of helps us. I'm a little more comfortable if a patient brings themselves and says, you know what, I think there's a problem, because one, that might either mean that even if eventually you do have dementia, it's very earlier on. But if a patient is brought in, and that's typical, the patient is brought in by their loved ones, you know, and won't be by one person, because this person will have talked to other people who will be saying, yeah, notice something different about mom or dad or grandpa. So there'll be a couple of people coming in, not just the spouse, maybe also a child as well. Once again, repetitive conversations, you know, you came to see me, you moved out, you brought the grandkids home, and you come to see mom or dad, and they ask you, how is so-and-so? Okay, so-and-so is in school. He did really well last term. Okay, 10 minutes later, how is the same person? You know, so this tends to happen, that repetitive conversation. There's also the issue that Manka brought up, and sometimes if it's not brought up, I tend to ask, you know, if it's the female in the house who will do most of the cooking. This is Kenya. Okay, I'll ask about, you know, how are the meals? Are there lots of burnt meals? You know, has the tea been left to overboil? Because we boil our tea with the milk, you know? And so those also will bring up an issue that nobody had really thought about, but when you mention it, people come up with, yeah, that's true. I mean, we've practically stopped her. We've let whoever usually does most of the cooking just take it over. The getting lost in places is also a big thing. That's usually a trigger for patients to be brought in. I remember one particular patient who was brought in because they had left home to go to the usual, just, you know, it wasn't out of their way, but they didn't come home for 2 days, you know, and they were found completely disoriented in terms of where they were by a well-wisher, really. In terms of functionality, because those are the sort of questions we need to ask, as Katie said, are you able to, you know, do you run a business on your own? Are you able to handle the money? Have you felt like people, is mom always complaining or is dad always complaining that people are stealing their money in the business, when really it's just a problem of keeping track of money and digits and amounts? And so it feels like they're perpetually making a loss. Are people taking advantage of this? Have you noticed people want to help you with your money a little more and take advantage? In Kenya, we have M-Pesa, you know, are they feeling like money is disappearing from their M-Pesa and they're not even sure what's going on? They have no recollection of sending that money, and yet there it is on your screen that you sent the money. So it's pretty similar. And we would ask the same questions. And once again, like we said, it's a game of probabilities. So with that one visit, we might have a strong suspicion, but we will need a few more tests to sort of eliminate the things that can mimic dementia, but strictly aren't dementia. Like Katie said, a major mimic would be a mood disorder, because sometimes I tell my patients, you know, memory is affected by anything. For those of us in our younger days when we went out all night, you'll remember just lack of sleep. You won't be as quick the next day until you've caught up with that. Or if you've been having a long-term alcohol use problem, disorder, your memory won't be quite as quick. So it doesn't mean you have Alzheimer's dementia. You know, you could have other things affecting your memory. So rarely will we diagnose it just on the first visit, but we probably will have a strong suspicion. And that's why it takes a bit of time to come up with that.
Okay, and Katie, you can add on to the other things that mimic dementia. I know Judy has mentioned them, and touch a bit on dementia that adolescents eat. I'm in the kitchen, so if you see anyone there, my adolescents are eating. If you could touch on the dementia that hits, because it's not just an old age problem, it can hit people who are younger. And in the States, I know the concussion has been a huge problem ever since Bernard O'Malley. We have to own the African in us, right? Discovered it in football players. And Judy, I would want you to discuss Nduthi riders in that regard. But Katie, I don't know if you got lost, if I overtalked, but yeah, just take it away, whatever you caught.
let me see. So I can talk about, there
Or
are a
things
lot
that
of
mimic, mimic
things that
dementia.
mimic dementia. So again, I think the biggest mimic, and Judy also said this, is mood issues. So depression, anxiety often mimics dementia and can also be a part of dementia sometimes, which is confusing. But you know, there's a lot also acute psychosis, which is basically when people are having a problem with reality and delusional thoughts, where they think that things aren't what they are, or they those types of mental illness issues, they can often mimic dementia, especially in the beginning, because people become quite inattentive in some of those disease processes, and it can look very much like a dementia. Then, of course, also when what I commonly see is people coming in the hospital is something called delirium. And this is kind of another whole can of worms, I guess you could say, in terms of trying to delineate between dementia and delirium. When a person comes in to the hospital and they are not themselves, but it started very abruptly, or it started after an illness, or it started in response to some sort of awful, you know, stressor. Oftentimes that can precipitate people to suddenly be confused and not able to interact with their environment the way they once were. For example, let me give you an example. Somebody has your you know, mom or your dad gets a pneumonia. They've been coughing, they've had a high fever, and all of a sudden they're hallucinating, they're not able to tell you where they are or what time it is, what month it is. They are not maybe responding to you, they're sleeping a lot more. A lot of people wonder if that's dementia or a precursor to dementia. And so they bring their loved one in, and oftentimes, you know, the difference is that dementia is going to be usually a slow progression of loss of function, including memory loss, those types of things. Whereas delirium is a fluctuating mental state. So you have up and down. So people will sometimes be clear and able to talk to you. Other times they're in la la land. They can't talk to you. They're in their own head. They're having, you know, conversations with people who are no longer there. And when they have that big fluctuation and it comes on abruptly, that's much more likely to be delirium. And in that case, that's a medical urgent issue, and they need to be brought into the emergency room for that. Because oftentimes there is something else wrong with them, like I mentioned, like an illness that needs to be treated in order for them mentally to clear, and it's a reversible process. There are other things that mimic dementia or cause dementia. There can be acute intoxication, so of different things, so alcohol intoxication. People withdrawing from alcohol can also look like dementia. They can have, you know, can be very confused. They can be, you know, hallucinating. People who are under the influence of other different kinds of drugs can also mimic dementia. Let's see. So mood disorders, delirium, you know, oh, also I should mention certain types of infections around the brain, meningitis or encephalitis. So people coming in, people who have been, again, it's usually a much more either abrupt or over a 2 to 3 week period of people starting to act not themselves. Those types of things require a more urgent evaluation to determine if it's something else. Also, there are certain movement disorders related to, you know, that can also cause problems with over time. If you think about Parkinson's disease, where people start with a movement disorder with tremors or difficulty with walking, and then they eventually develop problems with their memory. But some people can develop very abrupt movement problems with mental problems that also need to be seen quite quickly. So I think those are some of the mimics, you know, and then if you think about more of the longer term chronic things that cause memory loss over time, There is one disease process called normal pressure hydrocephalus, which I don't want to get into too much, but it's a disease process that involves a decreased ability to clear fluid from inside the brain case, the skull, and that can actually cause pressure on your brain and cause difficulty with your ability to function over a period of months. And sometimes if we're able to release the pressure by taking some fluid out from getting like a lumbar puncture or taking fluid from around the spine area, sometimes we can actually cause people to have improvement in their cognitive or their mental functioning. That's an incredibly rare disease process. So I don't like to talk about it too much, because oftentimes people will come to me hoping that I can fix the person's cognitive issues by taking some fluid and making them better automatically. I just want to say though, that there are occasions where when you bring a loved one in with dementia symptoms, we do find something else. And that's one of the reasons why, even if you think it's dementia and you think it's something we can't do anything about, it's a good idea to get someone looked at professionally so that we can decide if there is something reversible or some other process that needs to be diagnosed. Does that help? I don't know.
It does. And in Kenya, delirium ni kuchanganyikiwa. And hydrocephalus ni kichwa maji. I have, Judy, you might kill me, but that's what people say, right? and Judy, would you mention, this is for Kijano Kijan, she knows, should want to know if the many boda riders, I know Kiri, you know a bit of the motorbike riding that's in East Africa, like it's everywhere. Are they experiencing a lot of concussion because of the whole bumpy road and hitting their heads in the skull? Have you been able to see that? And the very many rugby and soccer players in Kenya, have you been able to see like a progression to dementia the same way we are seeing in dementia pugilista, the boxers dementia, and the ones we are seeing in NFL players?
Right. So if we think back to this boda motorbike craze, I would say it's picked up over the past maybe 5 to 10 years back. And I feel, and like I said, once again, my disclaimer is we don't have a specific registry for these sort of diseases. So I can't give you figures in terms of how many we're seeing. So I'm really giving you anecdotal evidence based on what I see in clinic or based on what I hear other people see in their specialist clinics. We haven't yet started seeing an increase in, say, cognitive problems in younger people based on the fact that they were motorbike riders. Maybe it's a matter of time. Maybe we're still, in that window shed period where they need the process to have continued for a bit longer for us to start seeing that. But we are seeing a lot of broken limbs. So the orthopedics are having an avalanche of patients, and it's actually becoming something of a national emergency, to the extent that the government hospitals have had to set up units previously that they didn't need specifically for limb fractures. So we do know that, if you're getting a limb fracture, you probably are going to get a bit of a head injury. And so I feel we're probably just in this watershed area, and in future, we might see these patients coming in with, post-concussion syndromes, with problems with their memory. What we do see quite a bit of is memory problems related to chronic alcohol use, because alcohol use is also quite heavy in, of course, more so in certain areas of the country. And so we do see a lot of that, and we see a lot of it in younger people. So ideally, if it was your typical dementia patients, these are patients maybe over 65, but we are seeing it in much younger people. And when you take a bit of a history, you realize that there was a pretty significant amount of alcohol use. We also have a few mimics in terms of things like vitamin deficiencies, dietary related, B12 deficiencies sometimes, especially among people who are unaware of the fact that if you're choosing to go vegan, you do need to supplement your vitamin B12 at some point, which with certain demographic groups who are predominantly vegans, they are quite aware of that. But if you as a person are making this choice, you might not be aware of that, and you might not be doing it in the way it should be done. So infection, post-infectious diseases, because as you imagine, we have a heavy burden of infectious disease, diseases going to the brain, cerebral malarias, meningoencephalitis. So we do see that sort of memory problem in younger patients than patients we typically see with dementia. So to answer your question, we haven't yet started seeing the post-concussion in the motorbike riders. I think it's really a matter of time. We're probably going through the epidemiological transition, and eventually we will start seeing more of them.
And I think
I wanted
Carol,
to add one more. Oh,
sorry.
sorry.
Just go ahead. Go ahead.
I was going to add one more thing. Yeah, the vitamin deficiencies is a very big one for mimic. I had forgotten to mention, and then also certain endocrine things like thyroid disorders too. Sometimes we see people coming in, confused or having mood problems that look like early dementia, and they actually have, thyroid disorders or something like that. So that's another one I wanted to mention. Sorry.
Okay. Carol, I think that answers part of your questions, unless you want further clarification. Bugo, are you on top of a tree now? Are you able to talk to us? So Katie, you know this joke. We look for network on top of trees. So I'm just making.
I was on top of a tree. Yes.
Okay. Okay. Is the tree giving us a better signal now?
Yes.
Okay. So just, yeah, because we've talked about the symptoms. You can, because this is in honor of Jarius also. How did you can finish the story, and then we'll move to, I'll ask Manka something about the mimickers, and then we'll move to diagnosis and management.
Yeah, so with Jarius, like I said, she would respond to conversations inappropriately, like totally unrelated. She would, of course, I think somebody mentioned the people around her noticed that she had this going on. So many people took advantage of her. I remember one time when she couldn't go back to the farm, I'd do the farm runs for her, and I got, one of the days I went, a boda guy just stopped me, and he's like, "Are you so-and-so's daughter?" I said, "Yeah." "Well, she owes me 40,000 shillings because," and my mom used to do that. She'd buy gifts, just sweaters and shirts for the kids and shoes. But I realized I think at some point she wouldn't pay these people, and she would go back and forth with them about different things. So it was just accumulating different circumstances that weren't making sense. Or she'd go to the bank and withdraw her whole balance. So let's say she'd go to the bank and withdraw 700,000 shillings, and then her minder would come and tell me, "Your mother has 700,000 shillings in her handbag." And I'm like, why would she need 700,000 shillings? And when I'd ask her, she'd deny. And then 2 days later, she'd come to my house and say she needs fuel for her car. And I'm thinking, you had 700,000 shillings 2 days ago. Where did the money go? But the tough part was getting my siblings to see what I was trying to tell them when I told them something's wrong, But I had one very unscrupulous sibling who would then tell my mom, Bugo goes around telling people that you're crazy. And she particularly took advantage of my mother and robbed her blind, because she would tell her, "You see, you can sign documents, sign this one over to me, because why would Bugo go say you're crazy?" And then my mom would notice at some point that something was off, and then she'd want to come and tell me what it is. So one of the days she had lost some money, and it was we were in the process of administering my father's estate, and it was one of his accounts. And I said, "Mommy, what happened to this money?" And she said, "I don't know." And I said, how can you not know? You were at this place 2 days ago. This receipt tells me you withdrew, I think it was like 250,000, And she says, "I really don't know what I did with that money." And then she looked at me in the eyes. Her eyes got glassy, and she said, "Your sister took it." And I said, "But why would my sister take it?" She said, well, she said she needed some money, but she gave me 10,000 out of it. I mean, she would catch herself and she's like, what did I just do? You know, and then she'd come clean, but you feel like, I mean, she just, and that wasn't my mom. My mom was always well put together. I mean, she always had her stuff straight. She always, so to me, there was just signs along the way that just didn't make sense.
Okay, because that was hard, and this is Kenyan. That was difficult to hear, and I think Katie and Judy, you've had these stories. Manka, I think you've had the same stories from the community. But is the community aware of the mimickers? You know, the ones that the mimic dementia.
So I think the challenge is that a lot of people do not even, like Bugal was saying, mom is crazy. We do not have, from the many African countries that people are coming from, they do not know about dementia, they do not know about this condition. And well, typically dementia is a condition that happens in most people late in life. So we find that in a lot of African countries, the life expectancy used to not live to be 60. So we're not seeing a lot of people living long enough to maybe begin having those kinds of cognitive problems that would happen at that age. But now we're having longer life expectancy, which is good. And we have a lot of people that are living longer. So now we're seeing a lot of cognitive problems. But in the African immigrant community, most people do not see that back home. They just do not have grandparents that live long enough to recognize some of those things. So we have no recognition of that this is pathologic, or we have no recognition of this kind of memory, this kind of poor judgment, this kind of challenge is actually a problem. So the big thing we do is we say it's craziness, or the next thing is you're cursed. And so those are the things that people would tie those losses of memory or those poor judgment or poor cognition things to. And so what we find is that when people start recognizing it in a family member, they want to hide it because it's not recognized as a problem. It's not recognized as not a problem. It's not recognized as a health issue. And so if it's not a health issue, then there's something else that is wrong and we don't know what to do with it. So let's hide that person, which is the challenge that we're finding. A lot of people are caring for someone with memory loss in the home, but they don't want to tell anybody. And so once they start having a conversation with people, then they begin to recognize, oh, maybe this is a medical problem that is happening and we can bring the person to the provider. So what we're finding is because people do not even recognize it as a health issue, they are not really thinking about, oh, what else could be wrong? What is wrong? It's just there's something wrong. Maybe mom is cursed, maybe somebody's been wished them, maybe something has happened, and so they keep them. But also the good thing that we're finding is that most of the African immigrants in the United States have been able to work in a health-related job. So that's the place where a lot of people recognize dementia because they had cared for someone with dementia in a professional capacity as a nurse, as a PA, as a PCT, as a CNA. So those roles have been what a lot of people say, oh, this is now when I know that this is a health issue. And so whenever they hear of a person in the community that might be suffering from something like this, then they tell that family member, your mom could be suffering from this thing. Why don't you take them to the doctor? So that's kind of the perception that we're having in the community. So because there's a lot of limited education about it, there's no recognition about, oh, there's this kinds of things that could mimic dementia. We really, the word we're not using as much as we should be, and we're not recognizing it. And that's why a lot of the people have been calling for a lot of education about dementia in the community. Yeah.
Okay, I don't think I know the Swahili name for dementia. I don't think it exists.
I have asked that question to at least 20 African immigrants in the United States, and there is no name in most of the Nigeria, Cameroon, Ghana, Zimbabwe, Sierra Leone. I've asked a couple of Kenyans, like those are some of the countries I've asked people from there if there's a tribal name for dementia? And the answer is no. And the part of the thing is that it's just often recognized as losing their memory, losing their mind, or whatever word relates to memory and cognition, or any of the symptoms that a person is portraying. That's how they refer to the person. Yeah.
The people who came up with saratani and shinikizo la damu for hypertension need to come up with a name for dementia. And I'm just, okay, Manka, you brought up the stigma part. Hey, this would make this conversation too long, but I'm just wondering, there's a neighboring Bantu community, the Kisi tribe, which is a huge population here, has been having a whole moment of banning their elderly women in the name of witchcraft. And I think part of it is economic front. They want their land, but the huge deal, I believe, and Kwasa, Judy, you could correct me, is that it's unrecognized dementia. Could you just comment on that before now we just go to the diagnosis and touch on hypertension and dementia? Someone has asked that in the chat. Yes. And genetics. Oh, good. Okay, everything is coming up. And please send the questions to the chat so that I can slip them in when I'm asking these questions. Okay.
So yes, I heard about that, the older witches being burnt. I didn't quite wrap my head around it, and I hadn't actually thought of it in terms of dementia. But that's an interesting thought. I thought of it in terms of some neurological disease, maybe some form of epilepsy, which is also really, really highly stigmatized. And the fact that with epilepsy, you can have psychotic episodes, so the patient is quite acutely unaware and confused and doing very absurd things. And this is thought to be their normal state, as opposed to this being an exception to their normal state. But yes, so I guess that's something I hadn't really thought about.
Okay, yeah, I think we can find out how these witches are presenting before they are burnt at their stake, literally. And yeah, it's a question. Could you touch on the genetics? I know on in the States we do the ApoE for, at least for the Caucasian population. I don't know what our stats look like in Kenya in terms of the ApoE gene, and talk about blood pressure and dementia.
Okay, I'll start with the first one, which is very easy because it's covered by a blanket statement. As is, we don't do any genetic testing within the country. So any genetic testing, if we had a strong suspicion, be it dementia related, be it types of epilepsies that we think are highly genetic, or we don't do them. We'd have to send them out. And as you can imagine, in terms of cost, that's really quite costly. So it's not something that we do regularly at all. So frankly speaking, in my practice, I've not seen a single ApoE, diagnosed patient unless they're coming from the States and they've carried those results. So it's not something that I would routinely send for by any means. Now, that said, does it stop us from making the diagnosis of dementia and coming up with a relatively high suspicion that this might be an Alzheimer's or this might be a Parkinson's related one? Not too much. We're still able to get by. I know we could get by even better with the use of these tests, but we're working with what we have, literally. So somebody asked, I think Edward Wasonga asked, can the extended use of blood pressure medication accelerate the occurrence of dementia? So no, it wouldn't. But just like in medicine and in everything, there's always exceptions to the rules. So when a patient comes in with these complaints of memory issues or dementia that is high on suspicion, I tend to ask them to show me all their drugs. Now, the thing is, please pardon the noise, it's evening, all the boys are playing soccer. So I tend to notice that patients will give you the drugs that they believe you want to know about. So what I encourage my patients to do is tell them to take photos of everything at home, and not just the tablet, because then I won't know what that tablet is, but take photos of the packets. And there are a lot of medications, especially in elderly patients, because elderly patients deal with their drugs quite differently. Their bodies handle drugs quite differently. So you'll find a lot of drugs that the patient might be on for something totally different that actually is affecting their memory or their ability to sleep, which is affecting their memory. So blood pressure medications, no. All right, unless it's a drug that, you know, like a diuretic, which makes us pee more so that we can bring down our blood pressure, and they're taking it at night, so they're always in the bathroom, and so their sleep has just been really lousy over many, many months, so their memory might not be so good. But strict causal relationship, no. The second part of your question, does having high blood pressure as a condition lead to higher chances of getting dementia? So that I would say is a yes, because if you remember our first slide, I think you showed it, Posa, vascular dementia was the second highest cause of dementia in terms of percentages. And as Katie had mentioned, and I reiterated, vascular dementia has a lot to do with problems that interfere with your circulation to the brain. So things like high blood pressure, and by that I mean high blood pressure that is uncontrolled, diabetes, problems with your cholesterol. So yes, that was the slide. So vascular dementia is the second leading cause, at least in my anecdotal studies, of dementia. So having high blood pressure and not having it treated is actually more dangerous in terms of dementia than having it treated. So the drugs are your friends as opposed to them being the enemy. Maybe Katie has a different spiel on this.
And Katie, you can also comment on the stress part. Someone is asking the relationship.
I didn't catch those. So
Oh,
the
it's in
question about stress. What was the question?
I'm curious about high stress levels and memory, and if extended stress levels can be a cause of dementia.
Okay, so I agree with Judy about it. I mean, basically everything she said is spot on in terms of the medications. In regards to vascular dementia, you know, long-standing untreated blood pressure problems, long-standing untreated diabetes problems, cholesterol problems, those types of issues, and alcohol really, can cause dementia over time. And so we generally recommend that if you are diagnosed with one of those conditions, it's a good idea to stay on your medications in order to help prevent the damage that can occur with long-standing untreated conditions. In regards to stress levels, it's a very interesting question. Again, this is part of the mystery. I think long-standing stress overall is linked to higher levels of chronic disease. And we don't exactly know, it's not a causal relationship, meaning high stress doesn't necessarily cause you to have medical disease or dementia, but high stress over time is linked to higher degrees of medical illness, including blood pressure problems and everything else. And so, it can lead to changes in your the way that you process, you know, your emotional states. That can actually cause mimics of dementia as well. And so I think, you know, and Judy can help me with this too, but I think stress over time is something that we need to bring out into the open and try to mitigate and try to help people realize that it's something that we need to talk about, to receive help for, because it's a general indicator of your overall health, and it can overall lead to poorer health, and in poorer health can lead to dementia. Does that make sense? I know it's not an exact answer, but we don't have an exact answer for that. Judy, anything else to add to that?
Yeah, it's not you get bitten by a mosquito and you get malaria type of answer. Judy, do you have any addition as we now move to how you actually make the diagnosis?
No, I fully agree with everything Katie said. So like the summary statement you said, so high level stress over time gives you so many other health issues. Some of these including things that put you at risk for vascular problems, put you at risk for mimics like depression or mood disorders. And so in a roundabout way, you could say so, but if you're looking for a direct line to dementia, no, but in a roundabout coily arrow sort of way, maybe, yes, yeah.
Okay, so let's just move to how you guys make the diagnosis of dementia. And Buba, will start with you because I know Jerriot's journey started from Dr. Catherine Mutisia, who's a psychiatrist, and then moved to the neuro side. Just tell us how you went about it.
What I did is first, I needed to find out, like you guys were saying, there is unrelated, there's other causes of dementia, and I wanted to rule that out. And that's why we went to see Dr. Mutisia, because I thought maybe it is something else, not the dementia. So after a few visits, which I think we did about 3 visits, one when I took her myself, the second one, Dr. Mutisia said she wanted to see her without me, just so that she can talk to her and get the information that would let her know what was going on. So she saw her twice or 3 times. And then she said, yes, I think it's dementia, but it's or Alzheimer's, but we need to go see the neurologist so that they can do the scans and look at the specific parts of her brain. And so we went and saw the doctor who did that. And yeah, so that confirmed it. The scans confirmed it.
Okay, and so let's start with the country that has more staff, right? So that's Katie, that's you, because you have more staff available for you to make the diagnosis. And if you have an algorithm of as how you go about this, that will work too. How do you exactly just go about making the diagnosis? And I know the clinical scenarios in both countries differ.
From it's a little bit different depending on exactly where you are in the United States as well. However, the first thing we do is we gather a history, right? So people come in and they tell us what's going on. And if we have a high suspicion for dementia, generally speaking, we'll start with the lab work that Judy and I both mentioned for mimics. So the B12 levels and maybe some other things that we are wondering about, maybe a thyroid test, those kinds of things. And we would also gather a history about alcohol use and other things, mood problems. And then we often will do an MRI of the brain. This is there are two major types of brain scans that we do commonly. CT scan of the head and then MRI of the brain as well. And the MRI of the brain is a little bit more sensitive for things that that could potentially mimic a dementia diagnosis, including, brain tumors, those kinds of things. And so we often will get that in our initial conversation. We'll order it. After we get those first pieces of information, we'll often try to send someone for something called neuropsychiatric testing, which is a round of very, very extensive question answer type of thing. It tests cognition, and it's usually administered by a special psychologist who specializes just in this type of testing. And it can sometimes last up to 4 hours. They'll sit and they'll do these tests that test all sorts of cognition, from their spatial abilities to their memory abilities to their ability to get words, try to come up with words in a certain amount of time. And that often gives us a better indication of where their problems lie, whether they're having issues with their memory particularly, or whether they're having issues with their ability to differentiate money, or whether they're having more trouble with their ability to find themselves in space, those kinds of things. And that can actually give us, or whether it's mood related, and that can give us actually an area of the brain that's causing a problem and can help guide diagnosis. There are genetic tests that can be done. We don't commonly do them, but we do them sometimes. And then there are also some metabolic types of scans that can be done. Again, not done commonly, but they can show you areas of the brain that aren't functioning as well. And then sometimes if you go to a very high level hospital in the United States, like the Mayo Clinic or in Boston, sometimes they'll actually do tests on the spinal fluid. They'll take spinal fluid and send that for biomarkers, which is things like, amyloid that can be seen sometimes that can lead to the diagnosis of Alzheimer's, but those are not commonly done. Those are only done in cases where there's some sort of suspicion for something else and we're trying to differentiate between two different things. So usually people come in, we're doing a clinical history, we're getting an exam, we're often doing a small cognitive test that takes about 10-20 minutes to kind of give us some idea. Then we're going to get some labs, we're going to get an image like an MRI, and then we'll have people go for further testing of their cognition. And then they come back to us in a second or a third interview and we explain to them what we've come up with. And then from there, it's, what our options are, which we haven't gotten into yet.
Judy, and I know you straddle both sides. You go to Kenyatta National Hospital, and you're in private practice. What are you able to give? And it's just what it is. What are you able to give the Kenyatta National Hospital patient, and what are you able to give the Nairobi Hospital, the African Pavilion patient?
I like the way you've dichotomized it, so that makes it easier for me. Thank you. So,
sorry, let me just Katie, Kenyatta National is the HCMC, but third world HCMC, and then Nairobi and Aga Khan is Park Nicolette Alina. She understands. See, it's good to be of both worlds.
We had, I remember seeing Aga Khan too in Tanzania when I was in Dar es Salaam too. We had those.
So the procedure would be really very similar to what Katie has just mentioned. And as she mentioned, even in the States, not every facility will be able to do certain tests. So I would say the baseline is we rely very heavily on history and physical exam, because that's going to tell us a lot about this patient, the progression, and it's very useful for the patient to come in with a loved one, preferably not just a loving relative, you love your mom from 3,000 miles away. I want somebody who actually lives with your mom, so somebody who lives with that patient. And we'll spend a lot of time on history. And as Katie mentioned, we do a short mental assessment just to see how they're processing questions, how they're answering them, how their recollection of time and their ability to tell where they are and where home is and what the nearest supermarket is, those sort of things, and the ability to deal with numbers. So these sort of help us put things in perspective, whether this pattern fits a dementia pattern or whether this patient just seems generally very sad, and very withdrawn, and maybe that's more of a mood problem. So after that, the examination, and this is where I think patients have difficulty, because they expect that if there's going to be a diagnosis of dementia, then there will be something we'll find on examination, but really, examination is more so to rule out some of the mimics. And so if your examination, when I finish examining you and I tell you your examination is normal, people look quite surprised, like, how can it be normal? And I can see my mom is struggling. Oh, my dad. I don't know why I keep going to moms. Okay, or my dad. So normal is a good thing. It just means that some of the mimics that would come up are less likely. And then we go to a panel of blood tests, of which, just as Katie mentioned, we look at the thyroid, we look at your vitamin B12 levels, we look for infection, even chronic diseases like syphilis, we pay particular attention to because it's a silent disease. You won't know that you have it. Most of the time, it will do nothing. And so we test for it either way. We look at your kidneys, your liver function, and some tests for inflammatory disease, which can also affect the blood supply to your brain and give you the second type of dementia. So eventually, now this is where we dichotomize into Kenyatta and other places. So when we're planning imaging, because as you can imagine, everyone is paying out of pocket. There's only, I think, 20 or 30,000 people on health insurance in the country, excluding NHIF. So NHIF is the equivalent of our national insurance, which is tiered into different levels of contribution, covering different levels of care. So at the lowest tier, basically you're paying 500 shillings a month, which is about $5 or four point something dollars a month. But the kind of care you can get with that is it won't cover for an MRI. So you'll still need to pay, and the average price for an MRI is about 20,000, which $200 give or take. I don't know everyone has that. So a lot of times at Kenyatta, we might not get the MRI. So we'll go with the basic CT scan, because really we're going to say if you can see anything overt on the CT scan, it helps us rule out these other mimics. If you have something growing in your brain, it's less likely to be dementia and more something secondarily causing your memory issues. That said, if money was not a problem, or if you're fortunate enough to have a really decent health insurance, then we will opt for the MRI. Now, this is where we completely diverge from the States, because we don't, well, by my last count, we had 4 neuropsych tests. I've forgotten their names, neuropsychologists, is that the word? Right, to do those tests. So we have not been able to send people for those batteries of tests. And as she mentioned, it can take up to 4 hours. I remember in my training, I went and joined one, and we sat there for 4 hours, and I was thinking, wow, there's a gap in Kenya. We need more people to train. So just in case you don't know what to tell your child or nephew or niece what to train in, there's a huge gap there. So we won't have the luxury of having those sort of tests, which are really useful in helping dichotomize which areas of your cognition are most affected. And because the different dementias have different patterns, that's really useful. So we don't have that. So we'll go heavily base it on our clinical judgment, which is a history exam and what we've seen in the labs. And then, come up with a plan. So once again, it won't be made on the first visit. That diagnosis will be made, when you're able to get these tests, depending on how liquid you might be, or depending on how accessible these tests might be for you.
Okay.
Can I ask a question of the panel, of the neurologists? Yeah. So you all both talked about the neuropsychologist testing. And I do remember that a lot of those tests are related to literacy, and some of the people presenting to, especially in the African immigrant communities, the older adults do not go to school, and most of the times are not education literate. It's not like they're not intelligent, but it's just some of the tests that created for certain types of schooling or certain levels of schooling. Can you all speak to testing people who did not go to school and how that happens?
So from my perspective, so when I was working at Hennepin, they often had people who were not literate or did not speak English as a first language. And that's not an easy thing to manage at those neuropsych tests, but they do have alternative testing available for people who are blind, or people who don't speak English, and people who are not literate. Whether they're as sensitive as the tests that were originally designed for, basically, let's be honest, for English speaking people with a certain degree of, certain level of education. I don't know for sure. I would have to look up that data, but we did have other options for people. It was not often not as extensive testing as the original neuropsych testing, but they do have alternatives for sure. Also sign language for deaf people, they do have, yeah.
Which is not available in Kenya. Do we have sign language in clinics now? No?
Okay, we have a lot more sign language literate. I don't know if that's the right term. Sign languages, I don't know. And actually, recently, like in the past 1 month, there's one hospital, I've forgotten its name, but they advertise that they're specifically aiming for that sort of market. So I think that's really remarkable, because that will be their niche, people who need sign language interpreters. I wanted to chime in on the question Manka asked, and I think that's a huge issue. I remember being involved in some HIV dementia study about 10 years ago, and currently I'm involved in a working group that's just trying to understand how best we can do these neuropsych tests to cater for the people with not just literacy, but different approaches to education. And because we found that Africans, Africans based in Africa seem to do much lower on the tests, even when we adjust for level of education. And yet it didn't translate to as much clinical disease in the HIV population. So this is something that has generated a lot of discussion. There's been a lot of, is this really the best way to test? So I think it's a really important question. We're still struggling with the answers and trying to come up with useful research to deal with it. And I myself did very badly on one of the tests, so I was a bit shocked.
I mean, let's just be very honest. There's inherent bias because these tests are developed, in Western countries by Western doctors who are, generally white people who've gone to school. So it's just this kind of like, there's just this inherent bias. It's a totally different culture. And, ultimately, like it's going to miss the nuance, I think, in terms of people from everywhere. And that's a problem in all of medicine, really. I mean, you could generalize that to all of medicine. Like there's just a lot of bias there. And how do we adjust for that? I think it's a conversation that's ongoing. And I think ultimately what is most helpful is to have people evaluated by people who are intimately knowledgeable about their cultural background and people who are very familiar with how things work, because I'm not going to ask the same questions as Judy is of her patients. When they come in and talk to me about a history, I'm going to be asking them about driving, or I'm going to be asking them about, I might ask them about cooking, but it's not going to be in the same context that she will. And so I think ultimately you cannot put a value on the importance of having somebody evaluating your loved one who is kind of intimately familiar with their cultural background and their language.
And let me just give you an example. In my quest to get back to medicine, because I have been home for 7 years, I've worked as an interpreter. And one of the interpretation sessions was for someone who had a traumatic brain injury. And the PTOT, you guys need to salute those guys, like hug them when you see a PTOT. Physiotherapists, occupational therapists, just salute them. So one of the assessments was how to get into bed. So there was a well-made bed and the patient had shoes on. So what did the patient, I could demonstrate, but you'll see my butt here. What did the patient do? He went and sat on the bed and just lay half of his body. So the occupational therapist was gonna say he can't do that. Then I was like, no, culturally, he cannot put his shoes onto the bed. And yeah, as in small nuances like that, I'm missing from all this. And the people who are funding these studies are not interested in what we want to study. They want to like tick some boxes there. It's a whole political situation. As Manka, as you comment on the testing option, I want to put back the slides for the brain so that Jane Kibwage, who joined after we had talked about the normal brain and dementia, can understand why her mother-in-law's dementia got worse after the stroke. But Manka, meanwhile, just comment on the community and the testing, what we had talked about before you brought up about the literacy point.
A little bit about community testing. I think maybe the biggest challenge is some of the things that you all have mentioned with the testing. So people are hesitant to go get testing. So we have to overcome the hurdle of not recognizing that dementia in a family member is a medical problem that needs diagnosed or that needs help care from a practitioner. And then once you overcome that, there's a ton of challenges that affect people getting out to get care. One of them is what Katie talked about, having a provider that is really culturally competent. So a lot of people are very hesitant to go to the doctor because the doctor is not going to understand them. And then a lot of people are not, some people come from systems where they did not have certain types of providers. I know Judy talked about in Kenya, there's an insurance scheme that gives you different levels of care. There are quite a few people from different African countries here that actually do not understand the primary care system, where they only go to the doctor when things are bad, when they're very, very sick. And so the concept of going to a doctor for a physical or going to the doctor when it's not really bad, it's new to them. And so they do not go get care. That's the second thing. The third thing is that they've also, a lot of people come from systems where they've heard a lot of bad things about the medical systems. I've had older adults tell me now, thinking about the COVID vaccine, they're like, when I was in primary school, they just got us and gave us a ton of vaccines and we had no idea what it was. I'm not going to the doctor because they're going to give me vaccines. They're going to give me medications and I don't know what it is. So these bad experiences with the healthcare system make them hesitant to go back to go get healthcare. So it's like a lot of the things that hopefully with education and kind of being familiar with the system, we can overcome, but there's a lot of things that are holding people back from seeking care for any of the conditions that they have, including dementia. And those are some of the few reasons that we're finding in our work with the community here. You know, the not understanding the medical system, recognizing that the doctor is not going to understand your culture and who you are and why you practice some of the things that you practice, and also not even recognizing that the healthcare system, how the healthcare system is set up to support you because they're not used to those kinds of health systems. Yeah.
Okay. Does anyone want to take a stab at Jane Kibwage's question on dementia getting worse with a stroke? And I have put my beautiful slides up again, and I can go back and forth if you want.
I can try to address it. So stroke is a process by which you lose blood flow to a certain area of the brain, and your brain is a very, as we mentioned before, it processes a lot of things very fast, and therefore it requires a lot of blood flow to bring oxygen and sugar to provide the energy needed to make all those functions happen. So whenever there is an interruption in blood flow, even for a period of a few minutes, we have death of the cells that did not get that blood flow. And that's what causes a stroke. And there are other kinds of strokes. There can be bleeding type of strokes as well. But the most common is the kind where you have loss of blood flow. And when you have that loss of blood flow and an area of damage then occurs to your brain, that is going to overall cause your cognition to take at least some degree of a hit, as it might be. So if you already have dementia, if you're already having a difficulty with dementia, what you're looking at is overall less cells that are functioning across the brain, right? Causing decreased functionality of your brain to do normal things. When you then add on top of that a widespread loss of neurons or brain cells in one area, you're again adding to that degree of damage, which can cause a decrease in your functionality to hear. What we usually see in stroke is a loss of function in one particular area of the brain. For example, in that purple area there, what we can sometimes see when that area is damaged is that blue area and the purple area and the yellow area. That will sometimes cause, that's a very common place for people to have a stroke. And we will see a loss of function on one side of their body where they're paralyzed or unable to talk on one side of their body. And if you think about the brain as having, when we're functioning at 100%, we have reserve, meaning if we get sick or something happens, we have a stroke, we still have, yes, our brain function may now be at 95% than other than 100%, but we can make do and continue to think clearly despite the loss of that brain cells. When you have dementia, your brain is functioning at a lower percentage of its ability. And then when you add a stroke on top of that, suddenly you're taking away another percentage point, several percentage points of ability. And overall, you're dropping your reserve and your ability to continue to think clearly. What we often see in people who have dementia, who then have a stroke, is they will have a sudden decline in their function that's much greater than we would normally see in a person having a stroke if they didn't have dementia. And then as they recover from their stroke, they will start to improve in their ability, but probably not back to the baseline that they were before they had the stroke, because they've created a loss of function that is additive. Does that make sense? Is that too much?
It makes too much sense. If there's such a word. Judy, do you want to, Jane, I know you slipped in and out, and maybe you might watch the recording later, but did that make sense? You can put a thumbs up. And Judy, do you want to add anything else?
I want to completely agree with Katie, and I want to extend it a bit further in that it's not just a stroke, but we know from studies of patients with dementia that any major life event, so we expect, if we are looking at a graphic, you can see through the blur of your ability and your condition, it generally goes down over time. But if you have a major life event, and it could be a stroke, it could be even the loss of a loved one. I had a patient who lost her husband. It causes a sudden dip. So usually you're going down quite slowly, quite imperceptibly, but then you get acutely worse. And as Katie said, you don't quite build up back to your baseline. And so you come to a slightly lower baseline and then eventually continue your steady decline. So any major event, and it could be an emotional event, the loss of a loved one, it could be a medical event, a stroke, a road traffic accident, a traumatic brain injury, which is what you deal with a lot with, of course, that can cause a sudden decrease in your functioning, and slowly, even though you pick up, you won't pick up back to your baseline.
Okay. And as you talk about the baseline, I think it's important to let people know the degrees of dementia. I don't know if anyone wants to touch about that. Bugo, you can tell us how Jerioth has been since diagnosis. Or before you exit now. Bugo, before the onions burn, you can tell us.
What was your question?
As in, how has what Judy was talking about, like from baseline, how has Jerioth dipped or has remained the same or has gotten better?
Okay.
Yeah.
So at the time of diagnosis, of course, the main symptom was the forgetfulness, the communication wasn't flowing like it should. And then as the years went by, so I think in 2016 is when she would be very, very aggressive. And she even at some point went into depression where she stopped talking. I mean, she just would sit there and not talk. But I thought maybe she has realized that we're not understanding her. She's not understanding us. So she just went mute for a while. And then she started having trouble walking, or it kind of looked like she'd forget she was walking, and then she just quit. But now she's total care. I mean, now she barely speaks. Of course, she doesn't recognize most of us. She has to be fed. I mean, she was feeding herself up until sometime last year, but now she has to be fed. She's in diapers. She has to have 2 people with her at all times. The one thing Jerioth has never lost is her appetite. As long as you put it there, she will eat it, which kind of makes her care a little bit more manageable. Because but I do expect somewhere down the line she might even lose that. But yeah, so it's been progressive. When she went mute, she gradually, she just started responding to people. Before she wouldn't, you'd say hi and she'd just look at you. And then at some point she started responding. And actually the interesting thing is now her responses actually make sense. You know, if you say hi, she'll say hi. If you ask her name, she'll tell you her name is Jerry. You know, so she won't engage in a long conversation, but those simple questions or simple conversation, she actually sometimes responds appropriately. So it's always welcome to see that.
Okay.
Yeah.
Happy birthday, Jerry. Go and just post the cake later. I'll just eat it per macho.
She's busy munching that cake. So let me go and join her.
Okay, thank you so much.
Thanks,
okay, let me just get so that I know when to stop. Katie, are you still on call? Do you have a hard stop?
I have a hard stop at 10, yes.
Manka, you have a hard stop at 10. Yeah, Manka, oh gosh, okay. We have 14 minutes. Let's manage. The rest we'll find another day. Let's manage the patient and manage the disease. And that's the two of you. Judy and Katie. Can you let's manage dementia and then let's manage the patient. Who wants to start?
Do you want to start, since it's probably more, you know, the population is different?
Yeah.
Okay. So once we have I'll say a high index of suspicion that this is dementia, I tend to, and I think we both do this, I tend to counsel the family on what this course looks like. So it's a long-term disease. Like we've said, it's progressive. It tends to get worse over time. So we need to manage expectations. So like you rightfully said, this isn't malaria. We give you, you know, a drug, 5 days, you're fine. It's going to be long-term medications, and the patient will tend to be stable most of the time. That's what we hope. And stable is able to do most of the things that they enjoy doing. But over time, it tends to get worse. So that as we start these medications, we have managed expectations. As we start these medications, I'm also considering how it's interacting with all the other medications the patient is taking, because this is going to mostly be an elderly patient who has other diseases going on, the high blood pressure, the diabetes, the asthma, whatever that might be. And then we have a choice of a number of drugs that we can start. And usually, depending on the class of drug, we usually tend to start low dose and build up depending on the patient's ability to tolerate it, because they will have side effects, a bit of drowsiness. Some people might feel a little bit like their patient is getting more confused than usual. And then we manage that. So there isn't a single drug that we use. We tend to use classes of drugs depending on what we're trying to achieve. And part of what we're trying to achieve is, one, keep the patient a little bit more stable so that they're not going through these dips. Two, manage their aggressiveness, manage their mood so that they're easier people to live with and to help, because it's very hard when your patient is extremely suspicious. I think Hugo mentioned it, you know, her mom was suspicious about her because she had been fed the wrong information. So it's hard to live and manage such a patient. So we might introduce some mood stabilizers as well. Doesn't mean that your patient is crazy, because once people Google about, oh, she's introduced a mood drug, oh my gosh, is she saying my dad is depressed? No, it means we're trying to help it be a little more manageable. And sometimes we might even introduce some vitamins, which may have been shown to help these patients. So what I find is that because in this wonderful age of social media, there's a lot of information out there. Now, we all know that everything on the internet is true, not. All right, so sometimes I need to manage how much this poor patient is taking, because you as the loved ones are planning to give her an array of 5 different vitamins, and then I'm introducing 2 different drugs, and they're already on drugs for high blood pressure, diabetes. So you end up with 12 different drugs. So we need to manage that as well. And so a lot of times I ask the patients to just lay out all the drugs on the table, even at the 2nd or 3rd visit, so that I can help manage. This might not be necessary, this we need, this we don't. And that's where it goes. Over time, we manage what comes up. So if the mood issues come up later, we manage that. if the continence issues, unable to hold urine, it's getting quite difficult. It might not be a drug that but we bring in the lifestyle measures like timed visits to the toilet or diapers at night, just so that you end up with a dry night as opposed to having to change the sheets every night. So it becomes a long journey. I like to say in Kenya, we're thinking marathon, we're not thinking sprint, even though now we have a sprinter, yay, but we're thinking marathon. So that would be my approach.
Okay. Katie, I think this is your last rodeo because you have to go. And just any additional and anything that I missed out that I should have touched on. There's a lot because of time we can't discuss, but yeah.
I just want to also say that we have medications to help symptomatically treat dementias, but right now we don't have any medications that can reverse or prevent the disease process from happening fully. We can help sometimes mitigate or change it can kind of give an increase to their functional ability in the short term with some of the medications that we have. We can also help manage mood things and some of the side effects, the sleep disturbances and things that we see sometimes. But again, we don't have a cure for these diseases right now. There's a lot of research happening, and we're all hopeful because this is a huge problem for the world. Something like 60 million people across the world have dementia. And so I think I just want to say that, yeah, we have medicines, but we can't fix the problem at the moment.
Okay. Manka, I know you also have a hard stop in 9 minutes. Just talk about the community resources that so far you've discovered that are available. I know Bugo has told me there's a huge Telegram community called Alzheimer's Soldiers. It's on Telegram. It's run by Elizabeth Mutonga in Kenya. And if you want, you can Telegram. I think you can search and get into it. Katie, in case you drop off, asante sana. And I'll look for you.
Karibu sana.
See, you don't forget the Swahili. Okay, Manka, and Judy, is it okay if we hang out a bit and just tidy up the house once everyone else drops off? Okay. See, you're all nice people. Manka, go ahead.
Well, Bugo, I would love to join that group. I think what we're finding out is that out of necessity, especially in the African immigrant community, the community is coming together, which is not surprising because that's what we do, especially as an African immigrant community. Africans are community people, we care for each other. So the community has really come together. We have different nurses organizations that are doing education sessions for the community. These are all for Africans in Minnesota, so it's not Africans in the east of Africa. We have people that have created adore day programs that cater to the African immigrants. So they have African story time, African foods, and things that are very culturally relevant. We have churches and pastors that are creating places for people with dementia to come and stay back after church. So the community is doing a lot of things, especially education-wise, to really help people that are living with dementia in the United States. But a couple of things that I've learned that I want to potentially stress or recommend if you are open to listening is one thing I'm hearing is that we need to talk about it. So if you have a family member who is living with dementia, talk about it to people so that we all normalize this condition. We know what is happening so we can help each other. If we're talking about it, then it's not going to be in the closet as it's been. And then we all can come together as some people are doing to care for each other. And then like Katie was mentioning, there's a lot of research that is ongoing, but we're hesitant to do research. We need to take part in research. I say that not recognizing that as Africans and as Black people, there's a lot of mistrust, and it's rightly so because there's a lot of things that have been done to us that are bad. I do not deny that there's a lot of things that typical in the past, the research community has done to a lot of minority communities. So given that, I think there's a lot of change that's happening, but we need to begin to slowly get into research. And what I do as a researcher, I've been calling for research to make sure that they are open, they are fair, they tell you everything they're going to do with the research. You're collecting data, make sure it's anonymous, make sure that the community knows what is happening. So as you hear about research, ask the questions that need to be asked, and then take part in research, because what is happening is some of the clinical tests that are being used that are not validated in us is because that we're not part of the research. So now is our time to really come in, join the work that needs to be done, make sure that whatever research is being done has our voice, hears what is happening with us, knows what is happening in our community, so that once we find the solutions and the medications, we're able to use them. If research is still happening without us as Africans, as African immigrants, we're still going to face the same problems where medications are going to come and they're not going to work for us because we're not part of the testing process. So my 2 takeaway points is, let's talk about dementia, talk about with everybody, make sure that it's normal. It's a medical problem. I recognize that we have different religious beliefs, but dementia is a medical problem. We pray to God to help heal, but we also go to the doctors to get treatment. God created the doctors for us to go to them. So all of those things can work together, and let's make sure that we're part of research so that we can inform the treatments that are going to be developed in the future to help us.
Okay. Katie, you have 4 minutes and not to milk you dry. Do you have any last remarks?
Just thank you very much for letting me be a part of the discussion. I really appreciate it, the opportunity. And I have to say that the more that we can talk together as a community, the more we can hopefully, demystify this disease process and make it more and kind of remove the boundaries to having people seek care, and to realizing that this is something that they can get help for. I mean, even though we don't have a cure, we can provide a lot of resources. And honestly, it's not something that any one caregiver can manage alone. I have to really stress that. It is a village. It takes a village to really, really support people in this disease process. And our loved ones will be better for it. We don't have the best support systems, even in the United States, for this process. And they are a lost group of people, even here in the United States, in my opinion. And anything that we can do to help people bring this into the open and seek help is, I think, very important.
Asante sana, kwaheri.
Karibu sana. And I would love to be connected. If you want to give my number to any of you guys for future collaboration, please feel free. I would love to stay connected and keep the conversation going offline.
Okay, you all know where to get me. So yeah,
Ryan, thank you.
Yeah. I will connect you to whoever needs to. Manka, I know that your meeting is starting in 2 minutes. Thank you very much. Judy, has she dropped off? Okay, everyone has dropped off. Oh, you're still here. Sorry, it's because when people drop off, the screen changes. Okay, Judy, because this, I know it. I just want us to talk about prevention, and yeah, Manka, thank you very much. I'll see you soon, I think. Okay, bye-bye. Judy, let's just touch on prevention, and I want you to specifically address biohacking. Let me put up a slide. You know me. Share screen. Then we'll close after. Yeah, share screen. Why isn't it? Okay, share. Sorry. Okay, so the biohacking communities, which is basically by the people here who are saying that dementia is preventable, and they've called it type 3 diabetes. Are you able to talk about the prevention measures? Do they really work, or is it an inevitable problem?
Okay, so I'm unfamiliar with the term biohacking, but I'm going to just talk about prevention as, you know, as my understanding of it. And maybe you'll help me figure out if that ties into what biohacking is. So prevention, like we've said, just from that nice big umbrella slide you had, that a large percentage of dementia patients have what's called vascular dementia. So what this automatically means is that if we can help prevent some of these so-called vascular diseases, we will help prevent dementia in a decent percentage of patients. And by that, we mean diseases like high blood pressure, diabetes, problems with your cholesterol. And when we think about it, these are described as lifestyle diseases because we know that high blood pressure has a lot to do with your intake of red meat, intake of salt, lack of exercise, sedentary lifestyle. We know pretty similar things for problems with cholesterol. So, and for diabetes as well, preventing a specific type 2 diabetes has a lot to do with your diet, has a lot to do with your ability to keep your weight within a normal range and the ability to keep active. So when you read about dementia, you will hear about keeping active, exercise, keeping your weight within normal, all these different types of diets out there that are useful in keeping your weight normal, be it a Mediterranean or a keto. I'm not going to go into all those diets because there's a whole lot of them, but really it's about the basics. The basics is keeping your weight within normal for your height, keeping active, reducing the salt, the red meat, and the solid oils or the saturated fats in our diet. So that would cover a huge portion of vascular dementia. When we think about things like Alzheimer's dementia, because we know that it tends to happen in older people, we can't do much about age outside of a court of law, but we do also know that the brain is a little bit like a muscle. So just like any muscle, the more you exercise it, the bigger it gets, and the less you exercise it, the more it shrinks. So the brain behaves a little bit like that, and especially in Alzheimer's dementia. So you will find that people who keep up their level of brain activity, who are high functioning, who are doing the crosswords, whose life career was very cognitive demanding, people in professions, those people might tend, if they didn't have a genetic predisposition, might tend to even just have less of that so-called old age forgetfulness, so not typically dementia. But this is not to say, and this is going to be a little bit confusing, this is not to say that these people don't get dementia. We have engineers who get dementia. We have pilots who are constantly thinking about, variables and visual spatial who get dementia. But what we do know is the less you use your brain, the more likely you are to get a faster progression of your disease. So if you were predisposed to get it anyway. So this brings me to the third part, which is there is a genetic predisposition for Alzheimer's dementia, especially. And when we think about it in terms of lifestyle diseases, it would predispose you to that sort of dementia if you were in that group. And so sometimes you're fighting against nature. Sometimes you have a relative who definitely had Alzheimer's, then the risk of that familial disease being somewhere in the family, not necessarily just with you, but in that family, is higher than the normal population. So sometimes you're fighting against nature, but those are some of the things we can do. So I'll just go through them again. Keeping your brain exercise. So keeping that reading, keeping that crossword puzzles, doing the Sudokus, those things keep your brain exercise, especially after retirement, when you have less in terms of what to do. Those are some of the things. And then once again, lifestyle things, keeping your weight within the normal limit, reducing the sugar past the age of 40, reducing the salt and keeping an eye on your blood pressure and actively managing it. So not just saying, I don't want to use drugs, you actually need to manage it if you do develop these diseases.
Okay, yeah, that's basically biohacking and sleep. And just making sure, yeah. Okay. I don't think I have any more to add. I've sent some links in the chat. There's an awesome occupational therapist. Her name is Tipa Snow. She's on YouTube. she actually acts out all these various situations you see in dementia and explains it a bit different than what we've done. And I understood a lot more than I understood in med school through Tipper Snow's videos. Thank you very much, Judy. Unless do you have any closing remarks? Did I miss out anything? And how can people? I know the people in the States, you can't pimp them out. How do people reach you?
Okay. My closing remark, actually, it's brought on by somebody's comment. I'd have to scroll to see who it was. But my closing remark is, and I usually tell this to the patient and their caregivers, dementia is one of those rare diseases which affects the caregivers more than it does the patient. Your patient will be blissfully unaware of what's going on, and their life will be going on as usual. But to everyone else, it's very difficult watching your loved one transform before your eyes into somebody you hardly recognize sometimes. And the fact that with dementia, you get what we call lucid episodes. So your dementia patient on one particular time, at any time, will be perfectly normal. And you'll be wondering, was this person sick? And then they slip back in. So it's very difficult for the caregivers. And a lot of times, as somebody said, suggested in the chat, I do encourage the caregivers to go for some form of counseling and psychosocial support. And as Katie said before she left, it can't be managed by one caregiver. So if your mom or your dad has dementia, you can't just leave it to the spouse to manage it. It's a lot. It's a lot. It needs a lot of input. So where can I be reached? I'm happy to send my telephone number because I would be able to text. I'm going to put it in the chat box. I'm not so great with phone calls. So in case I don't answer your, right, so that is my number. In case I don't answer your call, please send me a text, because you might notice that I am much better with text just because there's a lot of things going on. I hope I'm sending it to the right person. Wait, hold on one second. Okay. So I've put it in the chat box. That's my number. You can reach out to me and we can come up with how I'd be seen. So I have a practice in Nairobi in Upper Hill area. And once you reach out to me, I'll send you the details of my practice.
Okay. Thank you very much. And thank you, everyone, for joining us. I hope we've at least made dementia make sense to you and to everyone else. And hopefully I'll find out how to share this video, and whoever gave you this link will be able to send this to you. Thank you, Asanteni. I shall pray for you and do in church in the next 3 minutes.
It's really been a pleasure. Thank you so much for having this forum. I think this needs to happen a lot more. Thank you.
Thank you. Karibu sana. Okay, you can drop off. I do not want to end the meeting unceremoniously. So just say bye and drop off. Good evening.
Right. Thank you. Thank you for joining.
Okay, yeah, thank you.
Bye, Pastor. Thank you.
Yeah, well, thank you. Bye-bye.
Thank you.
Karibu sana. Oh, Judith. Oh, I've seen you. Okay. Joy, asante sana. Nitamsalimia. Karibu, Edward. Karibu, Tracy. Thank you. Thank you very much.